guys, it's Olivia. Welcome back to your endocrine chapter. In this section, we'll be covering other causes of hyperthyroidism. So we've already talked about Graves' disease. Now we'll go over some of the other causes of hyperthyroidism that you will need to differentiate between on step 1. So first, remember we're talking here about hyperthyroidism. So I want you to keep in mind all of the symptoms that go along with our hyperthyroidism friend over here. Things like heat intolerance and diaphoresis. Remember, we're burning through so much energy that our person is heating up. Weight loss, we're burning through all those calories. Diarrhea, things are moving fast. Restlessness, insomnia, anxiety, fine tremors, palpitations, hypertension, all these things that could be caused by either drinking a ton of Red Bull or by a hyperthyroid state. And then finally, the increased fracture risk, gynecomastia, or abnormal uterine bleeding that can also occur as a result of hyperthyroidism. So that's your general presentation, but what are some of the individual causes of hyperthyroidism that I want you guys to be aware of? The first is toxic multinodular goiter. So toxic multinodular goiter is going to occur when we have these patches of hyper-functioning follicular cells working independently of TSH. And what I mean by that is that these follicular cells no longer need TSH to bind to its receptor on the thyroid to be activated and make T3 and T4. They are essentially immune to feedback. They are not listening to the feedback loop, and thus they're going to be constituently active, always producing T3 and T4 even when our TSH levels are low, and that will cause the hyperthyroidism. This is often due to a TSH receptor mutation. So those receptors are going to mutate and always think they're going to be receiving a signal, and that's what's going to cause your thyroid to think it should be producing T3 and T4 all the time. And then it's going to present with all the symptoms of hyperthyroidism that we've already talked about, in addition to a possible goiter. And there's several things that can cause a goiter, right? We've talked about iodine deficiency, Graves' disease. Now toxic multinodular goiter can also cause a goiter, but this goiter is going to be a little bit different, and then it's going to have multiple nodules. So it's not going to be a smooth goiter like Graves' disease with that symmetrical enlargement of the thyroid. It's going to be these individual focal nodules or bumps that are going to be on the thyroid. And if you see an image of this, you might see a very bumpy thyroid, kind of looks like a thyroid with a bunch of warts. That will be your multinodular goiter. To diagnose multinodular goiter, we're going to do thyroid scintigraphy. So we are going to feed your thyroid a bunch of radioactive iodine and see where it goes. And if we have these nodules that are eating up a bunch of this iodine, those are what we're going to call hot nodules. So if you look over here on our diagram, we have some thyroid scintigraphy, and this all looks pretty symmetrical, right? It looks like our thyroid is eating up this radioactive iodine just in the normal shape of a thyroid. What we would see if we had a toxic multinodular goiter was we would see more of these focal patches where we have a lot of iodine uptake, and these will be your hot nodules. And then we'd see some patches with no iodine uptake, because these are the patches that are going to be listening correctly to TSH. TSH levels would be very low because it's inhibited by the high T3 and T4 levels. So those areas of your thyroid would not be lighting up, thus only the hot nodules would be lighting up. Now, a quick note here, just because you have a thyroid nodule does not mean that it's going to be a hot nodule. This difference between a hot nodule and what we'll call a cold nodule is going to be whether it takes up iodine. So you could have a lump that takes up iodine, that would be a hot or a thyrotoxic nodule, and you could have a lump that's not taking up as much iodine, and that would be a non-toxic or cold nodule. And those nodules actually are going to be more commonly malignant. So our hot nodules with increased iodine uptake are rarely going to be malignant. Those are going to be the ones that we see in toxic multinodular goiter, which although it is releasing more T3 and T4 and causing hyperthyroidism, is very rarely malignant. Our lab tests in toxic multinodular goiter would be increased T3 and T4 and then decreased TSH. Remember, our TSH is getting negative feedback from the increased T3 and T4 levels, so it should be low. Similarly, TRH would also be low in this scenario. And then management, you can do radioactive iodine ablation, so we can feed your thyroid a bunch of radioactive iodine, effectively killing it, or surgical removal. Or we can use our thionomides. Remember, PTU, propylthiouracil, and methimazole are going to be those two drugs that are acting to slow down thyroid peroxidase and our thyroid hormone synthesis pathway. So those can also slow the effects of a toxic multinodular goiter, inhibiting its ability to create more T3 and T4. Now, the next cause of hyperthyroidism that I want to talk about is actually not an endogenous cause. It is extrinsic ingestion. So why would people take a bunch of thyroid hormone? Well, if a patient has access to someone else's levothyroxine, let's say, a common reason reason to take thyroid hormone is because one of the side effects of hyperthyroidism is rapid weight loss. And that sounds great until you think about the other side effects of hyperthyroidism, including the palpitations, the hypertension, and we talked about thyroid storm and thyrotoxicosis that can actually kill you. So definitely not a safe way or a recommended way to lose weight. However, some patients who are trying to lose weight very, very quickly will ingest exogenous thyroid hormone. So it's really important for you to be aware of the signs of this. And ingesting thyroid hormone is going to lead to a lot of the usual diagnostic findings of normal hyperthyroidism, increased T3 and T4, decreased TSH because we have a negative feedback. But then the key differentiating factor here is that we will have low thyroglobulin levels or normal thyroglobulin levels. If you remember over here in your thyroid synthesis pathway, thyroglobulin is going to be that molecule which have all of those tyrosine molecules that we attached iodines to, made MIT or DIT, and then we combine those to make T3 or T4 respectively. And then thyroglobulin is going to be cleaved to let T3 and T4 exit our follicular cell and enter the serum. In doing so, thyroglobulin should be released with T3 and T4. So if your body is producing a ton of T3 and T4 and releasing it into the serum, you should also be seeing pretty high levels of thyroglobulin because thyroglobulin was theoretically released with T3 and T4. If thyroglobulin levels are low, however, then you know that you're getting that T3 and T4 most likely from somewhere else. It's most likely coming from outside the body. And that is why low levels or normal levels of thyroglobulin in the setting of really high T3 and T4 is going to be a great clue that we are dealing with a picture of extrinsic ingestion of levothyroxine or other thyroid hormones. Additionally, you might see lower undetectable 24-hour radioiodine uptake. Feedback is actually intact in your thyroid in this scenario. So your thyroid knows it shouldn't be producing more T3 and T4 because you have a ton of it in your body. So your thyroid is not taking up any more iodine. It's not producing any T3 or T4. Those levels are just high because you're ingesting it exogenously. And that is why you will see lower undetectable levels of radioiodine uptake in the setting of an extrinsic ingestion of thyroid hormones. To treat this picture, we will just cease the extrinsic ingestion. And then depending on how severe this patient's symptoms are, we could treat for thyrotoxicosis if necessary. Remember your 4 Ps, maybe some propranolol. The next cause of hyperthyroidism that I want to mention is amiodarone. So amiodarone is a drug that does contain iodine. So it can cause either the Wolff-Chaikoff effect or the Jod-Basedow phenomenon. I have your Wolff-Chaikoff-Wolff here to remind you that amiodarone can have either of these effects, which can lead to hyperthyroidism or hypothyroidism. Additionally, there's a couple other mechanisms that amiodarone can interact with to cause hyperthyroidism, but here we'll focus mainly on the iodine mechanisms because I think these are more highly tested. First, if amiodarone causes the Wolff-Chaikoff effect, remember our wolf likes to live in hypothermic conditions, so this will cause a hypoproduction of T3 and T4. Usually that only lasts a couple days, and then we have what's called the Wolff-Chaikoff escape, where your thyroid kind of breaks itself out of this pathway and returns to normal regulation and starts making T3 and T4 again. If you fail to escape the Wolff-Chaikoff effect, however, then you will go into a hypothyroid state because you're still not making those thyroid hormones. And this is more commonly seen in patients who have Hashimoto's thyroiditis, who then get some amiodarone. That iodine will cause you to go into a hypothyroid state, and then you won't be able to break out of it because the thyroid regulation has already been disrupted in the setting of Hashimoto's. Pretty much the opposite of the Wolff-Chaikoff effect, the Jod-Basedow phenomenon occurs when you have autonomous thyroid hormone synthesis, so dysregulation of your thyroid that causes it to always be producing T3 and T4, leading to hyperthyroidism. So this is more common in things like Graves' disease or toxic multinodular goiter, which we talked about in this video. Remember, in each of these pathologies, we have kind of a rogue thyroid who is just making T3 and T4 no matter what its feedback loop says. And if we have this type of picture when we give amiodarone and give them a bunch of iodine, through the Jod-Basedow phenomenon, we are just going to suck all that iodine up and make a ton of T3 and T4. So this can actually exacerbate hyperthyroidism in both of these scenarios. Now, another more transient cause of hyperthyroidism is thyroiditis. So there's a lot of different types of thyroiditis. There's Hashimoto's thyroiditis, subacute or de Quervain's thyroiditis, acute infectious thyroiditis, drug-induced thyroiditis, and we'll talk about all of these later on in this chapter. But what I want you to know for right now is that most types of thyroiditis, while they usually cause a hypothyroidism in the end, may cause transient hyperthyroidism at the beginning. So a little different presentation, but still important to include as a possible cause of hyperthyroidism in a differential diagnosis. And then finally, I wanted to include pregnancy in this list because even though pregnancy will not cause a clinical hyperthyroidism, its relation to thyroid hormones is frequently tested. So in pregnancy, we have increased estrogen. Increased estrogen is going to lead to increased synthesis of thyroid binding globulin. Thyroid binding globulin, remember, is different than thyroglobulin. It is that molecule that is in our serum binding to T3 and T4, making sure that it doesn't get destroyed. So because we have increased thyroid binding globulin, we then have increased circulating T3 and T4 bound to the thyroid binding globulin. More T3 and T4 is protected, it is taken up by the thyroid binding globulin, and it just keeps circulating and circulating, so overall levels of T3 and T4 will be higher. However, free T3 and T4 levels remain relatively unchanged. And this is important because while T3 and T4 is bound to thyroid binding globulin, while it can't get eaten or destroyed, it can't really be used. So it's kind of in an inactive state bound to this thyroid binding globulin molecule. So although we have more T3 and T4 overall, because our free T3 and T4 levels remain relatively constant, we do not have a clinically significant hyperthyroidism in pregnancy. And that's really important. You won't see any of the hyperthyroid symptoms in pregnancy, but if you do the labs and you measure a pregnant woman's thyroid hormones, they might be out of whack. So don't be thrown off by that. Don't think that you need to start suddenly treating a hyperthyroidism in pregnancy because these thyroid hormones are a little bit higher than usual. Remember to focus on the free T3 and T4 and also look at the TSH because that'll be a little bit more reliable. I know it's a lot of information. Let's quickly recap what we talked about in this video. So there are a lot of causes of hyperthyroidism. And in evaluating these causes of hyperthyroidism, I think a great first place to start is to look at the TSH, the total T3 and T4, the free T3 and T4, and the thyroglobulin. If your total T3 and T4 is elevated, but your free T3 and T4 is low, then we're likely looking at a picture like pregnancy, where we just have more thyroid binding globulin floating around. If we have very high total T3 and T4 and very low TSH, and we have very low levels of thyroglobulin, that's likely going to be a picture of extrinsic ingestion, right? And then finally, if we have a low TSH and a high total T3 and T4, you're going to have to separate out between causes like amiodarone, toxic multinodular goiter, and Graves' disease. Think about number one, do they have a goiter? If they do have a goiter, is it smooth or is it not smooth? That can help you differentiate between toxic multinodular goiter or something like Graves' disease. And then additionally, is there any reason that they would be on amiodarone? If there's nothing about that in the question stem or their medical history, I would not go barking up that tree, but what is one way they might ask you about this on step one? Something they might ask you is a 15-year-old patient is brought to his pediatrician by his mother. Mom states the patient has been increasingly irritable, hyper, and has been sleeping no more than 2 to 3 hours per night. Yesterday, the patient complained of heart palpitations during wrestling practice and had to sit out. On interview, the patient is animated and speaks loudly and enthusiastically about his upcoming wrestling match for which he has been trying to drop a weight class. Laboratory tests reveal elevated T3 and T4 and elevated levels of thyroglobulin. Thyroid scintigraphy reveals multiple scattered areas of increased iodine uptake. What is the most likely cause of this patient's presentation? Well, initially they give us a wrestler, he's a teen, he's really trying to go down a weight class, so he fits this picture of rapid weight loss. This is someone I would definitely expect exogenous ingestion of thyroid hormone in. However, they told us that thyroglobulin levels were actually elevated. So that is not consistent with exogenous ingestion of thyroid hormone. So we've got to think about something else. They also tell us that the patient has thyroid scintigraphy performed and ends up with multiple scattered areas of increased iodine uptake. This multiple scattered areas of increased iodine uptake is really similar to the presentation for toxic multinodular goiter. So if I were answering this question, that is actually the answer that I would choose on step one. Hope after watching this video, you guys are a lot more comfortable with other causes of hyperthyroidism, and I'll see you next time.